it should be that way. Okay, back into physiology of why people have heart disease. Now it's pathophysiology, means we're going to introduce the disease process. We talked about lifestyles, both modifiable and non-modifiable, that gets a individual into a cardiac concept. And I mentioned profiling yesterday. When you think of a heart attack victim, if you close your eyes and think of a heart attack victim, who do you see? What? Describe the patient for me.
Older man.
Older man? Fat older man? About 6 foot?
Beer belly.
Beer belly?
Beard.
Huh?
Beard.
Beard? Okay. It's your vision. I can't tell you you're right or wrong, but it's your vision. Is that bias? Absolutely, it's bias. Bias will get you in trouble here. I wish I could eliminate bias, but I can't. Everybody has bias. I still have a vision of a heart attack victim, even though I've seen all shapes, sizes, colors, races, and everything of heart attack victims. I still have a vision of a heart attack victim. It's what I call a greasy white man. You know what I mean by a greasy white man? Caucasian male, dripping saturated fats. You know, it's just leaking from his pores. You just know his favorite, his favorite meal is wilted salad. Y'all know what wilted salad is? It's where you take lettuce and you go over here and fry up a bunch of bacon. You throw the bacon in the trash and you pour the bacon grease all over the salad while it's still hot. It's called wilted salad. He's smoking. Okay, greasy white man. I worked with a few of those at the fire department. They smoke continuously. They don't move. Their philosophy on life is, I've got a finite number of heartbeats. Why would I rev my heart up and use those up faster? And oftentimes that's the person who lives to be 98 years old. And you're like, how did you make it? And I didn't. But anyway, so we have those things that get a patient into this position, and you got to drop the bias, because just as many women have heart disease as men. Nobody said a woman. When you guys were talking out loud, no one said a female. Do they have heart disease? Absolutely. A lot of those are missed. Let me give you an example of how we miss that. Women with heart disease and suffering from an ischemic event may not, and often not, have chest pain. Their chest pain is absent. There's reasons for this, and there's theories for this. We have, their pain tolerance is different because they give childbirth. I'm not going there. I don't know. I can't say that as a male. But I know that they don't complain about chest pain. They complain about something more subtle, like nausea, and that was our chief complaint yesterday. And I could dig in my records and my photographs and see the EKG of a woman whose chief complaint was nausea times 3 days. This was in February. February happens to be Heart Health Awareness Month. And all of us healthcare people are supposed to wear red to promote heart health awareness, especially in females. So ironically, it was in February. This woman had chest pain for 3 days. She decides to call 911. Lucky for her, a female paramedic shows up and said, I'm going to go ahead and do a 12 lead on you, even though your complaint is nausea. She had ST changes, and we'll talk more about that later. The EKG was pretty indicative of her having an myocardial ischemic event. Therefore, the paramedic alerted the hospital with cath lab capabilities. Not all hospitals have that. We'll talk more later. And so she got a cardiac workup as soon as she went to the ER. Sure enough, she's having a heart attack. She's having an MI. She goes to the cath lab. She gets it fixed, or at least postponed by placing a stent. I know without a doubt that myself and other male paramedics could have looked at her and said, "You're nauseated times 3 days. Let me give you some of this magic medicine called Zofran or Reglan or something like that to get rid of your nausea. I will call the ER, I'll transport you and go, I've got a 63-year-old female patient complains of nausea. I've given her some Zofran, symptoms have improved, be there in 5 minutes." Now you two work in the ER. If they get a call that said, "I've got a 63-year-old woman nauseated, Zofran has relieved her symptoms," is she going to get a cardiac workup immediately? You're kind of setting the tone, aren't you? I mean, you're like, okay, we'll put her over in room 442 and I'll see her in a little while. Not a high acute, keep my eye on kind of room. That make sense? Because we're biased, aren't we? Lucky for her, I think she got a paramedic and got it fixed, a female paramedic. Just a little more attentive to that. So drop your bias when it comes to this stuff. 35 years old, do they have heart attacks or ischemic events? Absolutely. There's a thing called cocaine-induced myocardial ischemia. So you can take a 20-year-old who's dabbling with the white powder, and it's an extreme vasoconstrictive agent and could cause a cocaine-induced myocardial infarction. You could die of a heart attack from cocaine use or any stimulant use. You can blow it up on energy drinks. I've seen young females who are doing the phentermine route for weight loss and adding energy drinks to the mix to try to ramp up the metabolism, have myocardial ischemic events. College students cramming for finals get all jacked up on energy stuff and can have myocardial events. Get the old heart racing really hard, a little bit out of shape anyway. Your body just can't stand it. Drop the bias. It's okay. Stems from ischemia. So you need the definition of that word if you don't have it already. Ischemia means lack of blood flow, therefore lack of oxygen, lack of glucose, lack of energy, lack the ability to carry waste away from the cells. And these events are occurring because a coronary artery is occluded. It's either occluded or it's having a spasm. Do you know what I mean by a spasm? Like, you ever had a leg spasm? Like a muscle spasm? Your smooth muscle and your arteries can do the same thing, and when they spasm, they don't allow blood to go through there very quickly. So you can be blocked with a clot, or you can have a spasm in the artery. Did I tell you to avoid hyperoxia? Treat your patient's oxygen status up to 94 or better, but don't try to go for 100. Yeah, all the evidence is pointing in live studies. If you hyperoxygenate a patient, it causes the coronary arteries to spasm. So the one thing you're trying to prevent in a cardiac event can be worsened by too much oxygen. Your textbook says 94. The American Heart Association says 94. The American College of Cardiologists say 90. So for test purposes in this course in National Registry, we go with 94. You may find a local protocol that says 90. It's where the science and the textbooks don't agree. It's where the science and American Heart Association do not agree. But the National Registry bases their standards on the American Heart Association. And you already know I don't agree with it, so, but that's beside the point. So we have that decreased blood flow. The tissue becomes ischemic, and then left untreated, Murphy's Law says things go from bad to worse. And if you remember the other day, I drew two zones. This is the ischemic zone. And we hope that our blacked out bullseye, the dead place, is never created or at least limited. So we have a zone of ischemia, and we have a zone of infarction. So if you look at the model on the wall there, just take your marker and black out some of that red tissue. If you black it out, we're going to call that dead. Dead means infarcted. The area around that obviously is ischemic. If you did not intervene, this area would grow. Obviously, when it grows, it's worse. So we have a saying in this business, time is tissue. So you can put that kind of in quotation mark in your notes. Time is tissue. It's such a big statement that your hospital and your EMS agency should be and probably will be measuring time. And it starts at first, when does the clock start? If you're going to measure this, when does the clock start? Well, I can't measure it if I'm not there. So we just have to start where I know I can. That's called first medical contact. An EMT or a paramedic on scene, the clock starts. We have to realize that it started before I got here, but I don't know when exactly. So if you're going to measure something, we have to have a firm starting point, and the only firm starting point we can get is Luke is on scene.
Not when they call them.
Not when they call. Not when they call. That's going to be that. Now, Jonah, don't get me wrong. That's going to be marked, and I'll know that time, and that it is relevant. Okay, but if I'm going to hold you to a standard, here's the standard. In other words, Jonah, you can't do anything until you're there, right? So that's the point we mark. So Luke is on scene and he has made contact with the patient. The clock starts. The next metric or the end point of that is, and they call it the balloon time. They call it balloon. The other word for that is cath. And basically what you say is, when does that patient get in the cath lab? When does that patient get that needle stuck into their wrist or their groin? When is the cardiologist ready to intervene? Got a 90-minute window. That's a long time. That's a long time. Once that window is bigger than 90, or that time elapsed is greater than 90, there should be a set of eyes going, what happened? What happened? So what is your role as an EMT in that? Christian, you want to take a stab at it? What is the EMT's role in this window of opportunity?
Help them and get them to the hospital before that time runs out.
Okay, so our transport time has to be removed from that 90 minutes, doesn't it? The time on scene with the patient has to be removed from that 90 minutes. And I think you had a test question out there, and I was grading some of these over the weekend, and if I didn't give you 100 on that question, or 10, there were 10 possible points, and some of you only gave 7 points or 8 points, and the question says, you've got a chest pain patient that needs to be transported to the hospital. Do you use lights and siren? And if you picked yes, you really missed it. I gave you a little bit of credit because at least you were going to the hospital. But this should be a nice, quiet, expedient transport. You don't stop and get lunch, but you get the patient to the hospital. Do you run lights and siren? The answer is no. Because you're going to ramp up a sympathetic response in that patient. They're really going to think things are even worse than they are. I don't even like them to be sitting in the home hearing the lights or hearing the sirens coming to them. Because if you're having chest pain in the recliner and you hear the ambulance 3 blocks away and you know it's for you, what's your heart rate going to do? Go up. When the heart rate goes up, is the workload on the heart going up? What's happening to our zone of ischemia? It's growing. It's growing. If I get there and I'm like, I'm not bringing the cot in, I need you to walk out to my ambulance. No, it's growing. Never make a chest pain patient walk. Quiet, calm, comfortable, all the way through. All the way through. I don't need 6 firefighters in turnout gear stomping through the house going, "Where's he at?" Never understood why firefighters on medical calls had to wear turnout gear. Guess it looks cool. Don't get me off on all that. But nice, quiet, calm, good conversation. Don't make your questions, put them at ease. Put them at ease. Provide confidence. Provide a comfort. The clock is ticking. That doesn't mean I'm going to sit there all day and talk to them. The other thing the EMT needs to do is acquire a 12 lead as quickly as possible. I mean, I'm not going to make that my initial assessment, but as quickly as possible, I need to acquire a 12 lead. Now, we'll talk more about that in a little bit, but basically I'm going to take this photograph of the electrical portion of the heart, and the EMT needs to send that forward. So you have to make a transport decision. Who do we take chest pain patients to? What, Billy?
Hospital with a cath lab.
Hospital with cath lab. Hospital with a cath lab. Not Bonham. We don't take them to Bonham. Why not? They don't have a cath lab. They can't do anything about it. Oh, they can look at it and go, yep, that looks like it could be a heart attack. We probably ought to send that on to Denison. So you have to know where your hospitals are that have cath lab capabilities. To date, as far as I know, and you can update me if I'm wrong on this, we have TMC and Wilson and Jones. I would, whatever Wilson and Jones is called now, I would have to call ahead at Wilson and Jones just to make sure, because they're bordering on sketchy. I'll just say it. I think locally you're going to go to TMC. TMC is an accredited chest pain center. They wear the seal of accreditation. That means that somebody has came in, the American College of Cardiologists, and looked at their stuff and says, you're good. That means for you, 24/7, 7 days a week, they should be able to get a patient in the cath lab. When I say cath lab, there is a table back here that the patient lies on, and all the instrumentation can go in and take care of this. It's not like there's a dozen of them. How many are 3 tables? Do you know?
We have
3 or 4?
we have 4 rooms.
4 rooms in the cath lab. And they're also using that for PEs, strokes, heart disease. There are times that cath lab is tied up. So we don't want anybody in the cath lab that doesn't need to be in the cath lab, right? And oftentimes this 12 lead that you're going to take and send forward is the one that says activate the cath lab or don't activate the cath lab. Just activation of the cath lab itself takes time. They have to call in the team. They have to warm up the machine, so to speak. They have to get everything laid out and prepped and ready. And a false alarm will not work. A false alarm will not work. So that's your role as the EMT, is to get that 12 lead sent ahead of time. Can you assist the patient with nitroglycerin if they have it? Can you assist the patient or administer oxygen if they need it? Yes. Can you give aspirin if your protocol says give aspirin? Yes. Can those medications change the size of this or maybe even eliminate it? Possibly. Will that make a change in the 12 lead? Yes. So when is it best to acquire the 12 lead?
First.
Before meds. Is it responsible to acquire it again after meds? Yes. And the cardiologist or the paramedic will interpret the changes made on that 12 lead. So there's a pre-med 12 lead and a post-med 12 lead. And if I'm transporting from Atoka, Oklahoma, I might send another one when I get into Bryan County, because it's been 15 minutes or whatever. These 12 leads change over time. They'll either get better or they will worsen. Does that make sense? So that's why it's so critical for you to get this and send it forward. The EMT does not interpret. In other words, they don't print it out and go, I think they're having an inferior wall myocardial ischemic event. You just say, here it is, you look at it. Now we transmit it forward with technology, either through, well, obviously through radio waves, but through mobile Wi-Fi hotspots and all that business. I'll leave that up to your agency to figure out how we do that. If you go out here on by the windows at the end of the hallway, there's a old cell phone looking thing laying there. It's big, and there's a monitor right beside it. That's the first one I ever used, and that could transmit, and that was in the 80s. So people say that they tend to think that that's kind of a new thing with Wi-Fi and stuff, but it's not new. Please remember, your goal is to limit the size of this or shrink it. You got 3 medications at your disposal to help do that, and the clock is ticking. You got 90 minutes. You got 90 minutes. Just for comparison, the last time I looked at these numbers, places like Atoka EMS in Atoka, Oklahoma, which if you don't know is north on 6975 north of Durant in another county, what would you say, 45 minutes at best to get to TMC Denison? That's on a good day.
Yeah. No traffic.
That'd be on a good day with no traffic backed up at the casino or anything. And depending on Atoka proper or some little rural area outside of Atoka, which is very rural up in that area, Atoka EMS has better times than Denison or Sherman. EMS, fire department. Now Denison and Sherman's 10 minutes from the hospital. And we're almost an hour. How do we have better times? Could be the amount of calls.
They like to drive fast.
That's that. Even when Atoka EMS has the patient for 45 minutes, half of that time, they still do better than Denison or Sherman, who only has them to 5 to 10 minutes.
There's less people in the house.
Less people in the house. Do what? They know they're on a time crunch? Well, so does Denison and Sherman. It's called ER dwell time. The ER is a busy place if you've never been to it. It is just busy all the time. And if you drop me somebody critical in with 5 minutes notice, it's a lot harder to manipulate and manage all the rooms than it is if you called me 45 minutes ago. If you give me 45 minutes heads up, well, we can get some stuff cleared out here. When you get to the ER, it's bam, bam, off to the cath lab. You've shown me the picture. You've called a patient report in. I have notified everybody around me that, hey, we got a cath patient coming. They call those code STEMIs, by the way. Just get the jargon out. Code STEMI. If you let that ER know 30 minutes ahead of time that you got a code STEMI coming, they can make some arrangements. If you give me 5 minutes, crap, let's deal with this. That's the reason. So the earlier you can notify the hospital, the more efficient they can be once you get the patient there. So when do I acquire that 12 lead? As soon as reasonably possible. When do I transmit it? As soon as I'm able to transmit it. When do I call in a patient report? Really, really, really quick when it comes to these patients. because you got a 90-minute window. Does that make sense to all of you? Oh, okay. Because time is tissue. We talked about these two conditions yesterday, and this is the atherosclerotic condition. This is just the buildup of that plaque. So you take that, we talked about cholesterol, HDL, LDL. A subcategory of that is something called ApoB. It's just another name for one of the lipoproteins. And that lipoprotein tends to bury off into the inner lumen of the vessel. So these coronary arteries have 3 layers. This becomes important a little bit later in the chapter. There are 3 layers. This is where the blood flows. So you got this layer, you got the smooth muscle layer right here, and then you got the outer layer. Jordan, they have names. The inner layer of the vessel is the tunica intima. Tunica intima. Tunica intima. That's the inside layer. That's the layer that the blood touches. That's where that ApoB, that lipoprotein, will kind of burrow in and irritate that epithelial lining. It's almost like you ever got a splinter in your finger or your foot or something, and it just didn't come out, and it got swollen and irritated and red. And if I think I have a piece of graphite from a pencil lead in 3rd grade, and it's in this finger. It's still there. I can see it through the skin. I often wonder what it looks like now if I take it out, but I know my body's encapsulated it because it's irritated it. That's what that ApoB is doing to that epithelial lining. It's irritating the hell out of it. And it makes it swell, and it kind of builds up, and now the diameter of that vessel is shrinking. And when the diameter of a vessel shrinks, I can't get as much fluid through it anymore. It's like corrosion in your plumbing. It's like rust buildup inside your steel pipes. The middle layer is called the tunica media. Media meaning in the middle. Tunica media. Or the medium. The outer layer is the tunica adventitia. Adventitia. Don't quote my spelling. I see it, but I can't get it out. Tunica adventitia. A-V-N-T-I-C-C-I-A, I believe. And you can see them here in the artist representation. This outer is the adventitia. The reason I say it's going to become important later, is when I have an aneurysm or a patient has an aneurysm, we're tearing through those layers, and we'll talk more about that in a little bit, but it's a good time to bring it up. So looking down into the artery, we have narrowing of the arteries, and what did I tell you about this irritation over time? It will lay down calcium, and then it turns into arteriosclerosis, and that's when it's just hardened with calcium, and that tends to lead to bypasses and stuff like that. You know, because cholesterol is one of those things that's always at the scene of the crime, but probably didn't commit the crime. Does that make sense? It takes a rap. We got to blame something.
So could that cause?
Yes, good question. I know it's going to be a good question. I ain't even heard it yet. Yes.
So could that cause ischemia to the heart?
Yeah.
Doesn't matter like if it's somewhere else, but it could just.
Oh, so your question is this only applied to the heart?
No, I was just asking.
So like if I've got a thigh muscle here and the artery that's feeding that thigh muscle has this built up in it, will the thigh muscle become ischemic?
Yeah.
Yes, absolutely. There's a name for that, Jordan. It's called intermittent claudication. So these guys This greasy white man that I spoke of, when he walks out to get the mail, he comes back in and he's like, it's killing me. I can't. Every time I go out and try to do something, my legs cramp so bad. You've had a muscle cramp, haven't you? In heart attack patients, that's occurring in the heart muscle. The deal is, if I know walking to the mailbox makes my muscles and my legs cramp, I just don't walk to the mailbox anymore. I send my grandson out there to get it for me. All right? The heart doesn't have a choice, does it? It has to go all the time. Billy, because the heart has to go all the time, and I have this artery coming here and I got this blockage building up in it. I got narrowing of the arteries. If it occurs slow enough, your body may actually build its own bypass. It may actually form a new artery to go around it.
So would it be better for that person to get up and walk, like even though it hurts?
I don't think sitting still is the answer to any of it.
What's the best way to do that?
What's the best way to make this happen?
Or no, like either clear it or make it not bad.
Well, you hope your body's got the sense enough to build its own if this is occurring. And it has to occur very slowly over time. You can't get a sudden blockage or a clot and then it does it. This is what the cardiologist is going to do if they make a bypass anyway.
I'm saying if we come across a patient that has that blockage, what are we supposed to do?
This occurs in the carotid arteries of people. Sometimes their mental status gets a little off. They're like, I'm forgetful. I just don't feel myself. The vascular people will look at the carotid arteries and see if they have blockage in them. You can actually take your stethoscope and lay it on the carotid artery, and if there was blockage in a carotid artery, you would hear the turbulence of the blood going by there. Instead of a clean, you'd hear turbulence, like, you know what I mean by turbulence? Like, yeah, you got a water hose and you start to kink it, you start hearing you hear the kink, don't you? You hear the obstruction. So what you would be hearing is often described as a thrill. The word for what you find in those arteries is called a bruit. That's an I. B-R-U. IT. It's called a bruit. It looks like brute, but it's called bruit. And that's cholesterol, not cholesterol, that's plaque built up in the carotid arteries. And they'll go in and rotor those out and wipe that plaque off. It happens in your femoral artery. That's why your leg gets a cramp. I guarantee you, though, 10 years prior to that happening, that man was impotent. And that is like the number one flag that says, we got a problem. By the time it clogs up a big artery, what's it done to the microvasculature in your body? I promise you, the eyesight's weakened, kidneys have weakened, the penis doesn't function anymore, the little capillaries at the end of the toenails don't function anymore, or the toes, and the toes look funny, and you get this, look like blisters on their feet. That was years before the big event happened. If I'm laying down plaque here, what am I doing up here in the brain? And all those cerebral arteries, I'm laying down plaque. Plaque doesn't care where it sticks. It's going to start sticking where the flow is slow. Where it's slow. I mean, even engineers who put in water lines and stuff, they have to know how many gallons a minute's flowing through that line, and that will give them an indication of what size line to use. It's got to be big enough to allow the flow, but it can't be so big because deposits will build up in it. You with me? Same thing's happening in your body. It's best not to have the cake icing floating around in there, causing the plaque. Billy, to answer your question. Did I answer your question?
Yeah.
Yes, it occurs everywhere. It occurs everywhere. It'll show up in our big two places first because they are so dramatic to our health, brain or heart. That's why you got 2 chapters in the book devoted to this. If it's in the brain, it's called a stroke. If it's in the heart, it's called a heart attack. If it's in the thigh muscle, it's called intermittent claudication. If it's in the kidney, it's called nephrology or kidney disease. If it's in the eye, it's called blindness, retinal deterioration. The problem is it's probably doing all the above. Which one just caught you first? Which one just caught you first? Let me add one more thing to this. That plaque buildup in there, it can break off. Just like in plumbing, that piece of rust stuck to the pipe could flake off. Once it flakes off and goes to moving, it is called a what? It's called an embolism. Yeah, you're right. It's a clot. It's something foreign that's floating around the bloodstream now. If it hangs up in the lungs, it's called a PE. If it hangs up in the brain, it's called a stroke. If it hangs up in a renal artery, then you lose flow to one of those kidneys. If it hangs up in the leg, then you got a deep vein thrombosis or an arterial occlusion. Got to keep the veins healthy, don't we? And we got to keep the blood inside those veins healthy. And we can't sit still. We have to keep these veins pliable. We got to keep them moving, and that's through activity and exercise and the demand on them. Use it or lose it. This is a muscle. It has to work. It has to be conditioned itself. So if you got a bad diet and you sit around and you don't do anything, now we're talking risk factors again, aren't we? So you kind of see how it comes full circle. So here you go, Billy. Thromboembolism. They just combine 2 words there, a thrombus and an embolism. If that lodges in an artery, you can have an MI as well. So not all MIs, not all arterial occlusions are caused by buildup of plaque. Sometimes we can just form a clot. So there was a thought process that's going around, and they're kind of disproving it a little bit. But a person who is on TRT, testosterone replacement therapy, testosterone increases red blood cell production. That's what keeps a young male healthy and vibrant and ready to go fight the battles, right? It increases red blood cell production, increases oxygen carrying capacity of the blood and the organism. Well, if I get increased red blood cell production in someone who is cardiovascular not fit, unhealthy, now take my greasy white man again and give him testosterone, because he probably doesn't have any. And you're like, looking at your labs, you have no testosterone, it's like 30, and it needs to be 500. Let me give you some testosterone once a month in a shot form, or a paste, or a patch. And you increase red blood cell production. Therefore, you've got more pieces in the blood. Do they tend to make clots faster? Yes. And now the guy has a heart attack because a clot was formed and it lodged in his coronary arteries. What do they blame immediately? No. Yeah. They say, dude, if you hadn't taken the testosterone, you wouldn't have had the heart attack because it makes red blood cell production. You got a clot now. That's like blaming the car that the bank robber used to rob the bank. The cause of your problem was more complex than that. And so now we blame testosterone replacement for it. Now, is the guy going to feel good and feel like getting up and moving and exercising when he's got no testosterone? No. So you got to get to the root of the problem, and the problem is not just fixing a lab value. His lifestyle had to change, right? Everything needed to go along with it to be vibrant. So you see that. Would I find that in the sample history? Guys taking testosterone replacement. Possibly, if he admits to it.
Yeah.
Some are too vain to admit to it. But because of the increase in red blood cell production, it can do it. People with sleep apnea. So when I walk into their house or I'm in their bedroom and I notice a CPAP machine lying next to their bed, or they tell me that they have sleep apnea, or the wife complains about the snoring, if you're apneic during the night, not breathing, are you hypoxic during the night? What does your body do in response to chronic hypoxia? No?
Increases.
Who's talking? You? Does what?
Increases heart rate.
Damn, I thought you were there.
Increases red blood cells.
Increases yeah, y'all need to get together and collaborate and y'all come up with the answer. Increases red blood cell production because the liver senses this and secretes out erythropoietin. Remember that? That's why the athletes train in Denver. So if a guy's got sleep apnea, or a woman, there's my bias again. If a woman or a patient has sleep apnea, they get increased red blood cell production. Are they more prone to microthrombi, Billy? Yes. So testosterone could do it. What about estrogen? What about a woman who's osteoporotic? You know, she's hunched over, she's kyphotic, her bones are falling apart, and she takes estrogen replacement. Does that increase red blood cell production? Mm-hmm. See, we all thought it was testosterone, didn't we? But so does the estrogen. That's why males have estrogen, by the way, is for repair. You go tear yourself up with testosterone and the estrogen that's inside you repairs you. That could cause microclots. What about a young, vibrant female who's on birth control, hormonal birth control? She's at risk for these clots. Yes, we keep talking about it hanging up in the lung causing a PE, but it could hang up in the coronary arteries just as easily and cause problems there.
Isn't a STEMI from a blockage?
Or a spasm, or a buildup. We'll talk more about that in a minute, because we're not even using that term correctly in medicine either. So I'll talk about that when I get to EKGs. But good question. So we talked about the risk factors the other day, and I agree with these. Don't get me wrong that I'm saying this, but we like to blame stuff as humans. We're like, this is what's causing it. And we may go through, you smoke cigarettes, that's why you have an MI. I know people who have smoked into their 90s and never had an MI. It's your high cholesterol. I told you a large majority of people having documented MIs in the hospital have normal cholesterol. Who did what to do and looked up something called metabolic syndrome? Frank, you did it? What'd you find out? I know you're chewing. Who else did it? I'll let you get your apple. Gus? What is metabolic syndrome?
It's when you have three, like you're obese. It was, from the thing I read, you had to have three of the, like high blood pressure, high glucose levels, and obesity.
Like 3 of the 5 or something. One isn't enough, but you got to get a few of them, then all of a sudden we have a syndrome. What was it a precursor to? Luke, did you look it up? What's it a precursor to? Or what do you think? What do you think would happen if you left it unchecked? Just let it run its course.
Increases your likelihood of developing type 2 diabetes.
Okay, yeah. All these are little bitty things, and all of a sudden, now you're a type 2 diabetic. Now you're a cardiac patient. Now you got an abnormal EKG and see a cardiologist. Now go see your kidney doctor. There is not a pill for metabolic syndrome yet. Believe me, if there were, they could prescribe a bunch of them. This is typically the 30, 35-year-old patient who goes in the ER, or not the ER, who goes in the doctor's office for a checkup, routine physical, and they say, your labs aren't looking too good and you need to lose a little weight, and your blood pressure is kind of borderline high. If you could back up one step, that's what metabolic syndrome is. And how many people have it? And at what age are they getting it? We won't talk about this in the textbook. It won't be tested. But this is for your own personal benefit, you and your family and people around you. I hate to sound so insensitive. And Regan's probably going to have to cut this. But at some point, you look at a patient or a person or even a loved one or maybe even yourself and go, at some point you got to do something. I'm out of medications. You can't, you just got to do something, right? That sounds insensitive. And perhaps it may be to some degree, but if I'm trying to find some clothing to fit someone, at some point it's not the clothing manufacturers for not making the size. Am I being too harsh there? It's like, dude, you're going to have to get a hold of yourself. You know, I have picked up 500 and 600 pound patients out of long-term care facilities, and I am not exaggerating by any stretch when I say this. I'll look in the corner of their room and there will be actual cases like you would buy at Sam's of Hostess products like Twinkies and Ding Dongs and cupcakes and Dr. Peppers by the case. We wouldn't do that to a drug addict. Something's wrong. Drug addicts if a mom is addicted to methamphetamines, alcohol, and all other sorts of illicit drugs, illegal drugs, and she has a baby that's born, and that baby's born addicted to those drugs because it's been exposed to them for 9 months, and this baby is in a NICU, which is a neonatal intensive care unit, and they're having to give that baby morphine and methamphetamines and everything else to keep them from seizing and wean them off of it. How horrible does that sound? It's happening right now. How horrible does that sound? What do you think should happen to the mother? Well, society says, but through the system of courts and laws, that they should be separated until mom gets her stuff right, and we'll see about it. Prove yourself worthy to get your baby back. But this baby's going to go into foster care because you can't take care of yourself. Does that sound unreasonable? Does that sound like that doesn't exist? Y'all know that exists? NICU number 1's got this baby in it. NICU number 2 has a baby in it who was born addicted to sugar. And you're like, huh? Wait a minute, what? Yeah, addicted to sugar. Mom didn't take care of her sugar intake during the 9 months, and the baby's pancreas is just running overdrive trying to do something with all this excess sugar that it's getting. When the cord is cut and separated from mom, that pancreas is just still secreting this high levels of insulin. Therefore, the blood sugar now drives down to a dangerous, life-threatening hypoglycemic level. This baby gets admitted to the same NICU, and instead of having methamphetamine and morphine dripping through an IV, it has sugar dripping through the IV to wean the baby off of sugar. One of them's going to get a prayer card from the church. The other one's going to get a jail sentence. And that pisses me off. Because that mother who is addicted to those drugs, the end result, if that's what I'm looking at, the harm to the child and the baby is still there in both cases. And I find as a believer in myself, and I'm not getting off into that, but as a believer in myself, I find it very hypocritical that one will make the prayer list and the other one doesn't. So at some point, we have to accept the responsibility that this heart disease that I'm getting is not anyone else's fault. Sometimes you lose the genetic lottery, don't get me wrong, but these are controllable, and I get so passionate about that. When you work a few CPRs in someone's house and the grandparents and the wife and the soon-to-be widow, you just haven't admitted it to her yet, is standing there praying and hovering over you, and I've had them lay their hands on me, while they're praying. It's like, please pray for the rescuer. You're like, can we back up 15 years when this started? So that's why I get passionate about it, and I have to excuse myself for that, but then again, I really don't apologize for it. It's just that big a deal. Uncontrollable, yeah, like you said, you lost the lottery, man. I don't like this here. That's so false. And being male, that needs to go away. Females are just as likely to have this as males. Atherosclerotic coronary artery disease, and they're calling that uncontrollable. That's not true. That's not true.
But once you've been diagnosed, then it becomes uncontrollable?
I think in today's society or today's medical, we often tend to think that. And I say that for this reason, Jonah. I've been in patients' home and they're like, what's your medical history? Well, I used to have diabetes. Oh, so did you reverse your diabetic stuff through diet and lifestyle? No, I take a pill for it, and my diabetes is no longer a problem. But people think, oh, I used to have high blood pressure. Oh, through lifestyle modifications, did you correct your blood pressure? No, I take a beta blocker for that, so I don't have high blood pressure anymore. That's how the medical system has geared our patients. That's how society's running right now. And why wouldn't it be? When all these medications are advertised on TV, why wouldn't it be just part of everyday life? Oh, there's a pill for that. There's a pill for that. I don't have to worry about ED. There's a pill for that. I don't have to worry about blood pressure. There's a pill for that. My mother's the world's worst. Bless her heart. Love her to death, obviously. I heard you had a cake up there. I'm like, well, yeah, but I've been keeping it a secret because I didn't want to tempt you. She's like, well, I'll just take another one of those metformin. I'll double up on it. Comes up for Thanksgiving. Did you make a pecan pie? Yeah, it's just kind of a Thanksgiving tradition. And I live by the 80-20 rule. I don't think life was meant to be miserable. I think you can have the cake and I think you can have the dinner roll, and you just kind of keep it in the back of your mind. It's like, dude, you had 3 rolls this week. Some people have 3 rolls per meal, It's the 80-20 rule, 90-10 rule. 80-90% of the time, I'll do good. Weekends, I'll probably kill a beverage or 2, But if it ever gets to the point to where I'm having to take medication to control that, then I'm probably like, hey, wait a minute, I'm going to back off and hold those horses off just a little bit longer. Jonah, it's sad, and you're seeing it firsthand in your job, and it's job security, right? We're all in here today because of this. It's the #1 killer. It's a big, big call. We're going to spend this week and the next week both practicing CPR and defibrillation and heart monitors and getting people to cath labs in a timely fashion. And you go to paramedic school, there are 5 college credit hours. For comparison, you're in 9 right now. With your 3 courses for EMT, you're in 9 credit hours. In paramedic school, of the 42 credit hours you will earn there, 5 of them are devoted to cardiology. So it's obviously a big class in itself. we spend a little bit of time here in a couple of days. It's a big deal. If you didn't know, the abbreviation AMI stands for acute myocardial infarction. Acute means sudden, myocardial means heart muscle, infarction means death. Jonah, back to your STEMI, we hope we catch that in its ischemic phase before it becomes the infarcted phase. The umbrella term is acute coronary syndrome.
Aren't all MIs acute though?
I think technically once it's an MI, it's chronic. Once you have an MI, it's chronic. Is that fair enough? If portions of this heart muscle actually die or infarct, you're not coming back alive. They become scar tissue. They become calcified scar tissue. They don't function. They don't conduct electricity. They contribute nothing to the heart other than a stiffened wall of the heart. That makes sense, Gus? It can't contract. It's kind of like a callus. It's just scar tissue. It can't do anything. Get enough scar tissue, how well does your heart work? Well, the more you get, the less it works. And it's forever. It's chronic. You can reverse ischemia. You can shrink this zone, but once you get a black dot, you can't reverse it. I don't know if I answered your question, but yeah. An acute myocardial infarction means up until this moment you had no dead cells, but once you have them, it's chronic now. And I can often find that on the 12 lead, possibly. I'll look at a 12 lead and go, I don't see signs of ischemia at the moment, but I can see you've had a heart attack in the past. And the reason you can see that is because that scar tissue does not conduct electricity, and it changes the shape of that waveform. Pretty cool, but it's not something you want to do. So we're going to subdivide the ACS into two terms, angina pectoris. Let's make this simple. That's ischemia. Ischemic muscles cramp. Ischemic muscles have a buildup of lactic acid. We're about to turn a very important corner here, okay? So please bear with me. I can change that. I can interrupt that as a healthcare team. I'm speaking universally here. As a healthcare team, I can fix the ischemia. Can't fix the infarction. When you go to a cath lab, when a patient goes to the cath lab, the cardiologist's job is to stop the spread of the infarction. But if it's already infarcted, cath lab's not going to stop that. Therefore, we're reducing ischemia. The term angina pectoris literally means pain. Angina means pain. Pectoris in the chest. Billy, that guy whose muscles were cramping in his legs because the arteries in his legs were clogged up, that's angina. Luke, if you go working out to failure and your biceps are just cramping forever, that's angina. We don't call it angina because angina, we like to reserve it for the big old heart muscle that we're also protective of. But it's technically angina. You could say it's bicep angina. Angina is the result of ischemia or lack of flow to the tissues. Can you go back 2 weeks to where we talked about the properties of cardiac muscle? Remember that lecture? The properties of cardiac muscle. And I was writing some things over here like dromotropy, inotropy, chronotropy. And then over here I was writing automaticity, contractility, irritability. Kind of remember that? And I said that the cardiac muscle has a unique ability to be pissy. I use the word pissy for a reason, so it'd stick with you. It has the ability to be irritable. And it also has the ability to respond to that irritability. Your biceps, Luke, when they get pissy, they tell your brain, can you stop? Because I can't take this anymore. And you go, okay, stop. But your heart, when it gets irritable, it says, I can't stop. You'll die if I stop, so I'm going to keep going. But it gets really irritable, and it has the ability to do something about it called automaticity. So what do you think could happen to these cells that are in the zone of ischemia? They're mad. They're suffocating, they're starving, and they're swimming in poop. Those cells are mad. Can they initiate an impulse due to the irritability? What normally initiates the impulse in our heart? There was that little specialized region high in the right atrium called the SA node. And it was the of the heart. It was the blank of the heart. It is the dominant of the heart. There's a word there I'm looking for. It's a compound word. Starts with a P, ends with an R. It's the dominant pacemaker of the heart, isn't it? So it's setting the pace. These cells down here real deep in the ventricle that are suffering, they get so aggravated they don't listen to the SA node anymore. They're like, I don't care what you're telling us. We're hungry and we're swimming in our poop. We're going to do something about this ourselves. They have went rogue. They start freelancing. Can I come over here, Gus? Mm-hmm. They start freelancing. And so I've got this normal looking EKG. It's regular. It's got all the components that I want. And then all of a sudden that ventricle cell gets so mad it sends out an impulse itself that looks like this. And then it kind of goes back to normal. And then it might fire off again. And these big ugly things you see on the screen are PVCs, premature ventricular complexes. I look at that and go, somebody's mad. EMT doesn't have to do that, but it helps to know what the paramedic's talking about, and it also helps you hear real quick because you're going to be treating this. If I get enough of these in a row, if I get so many of those PVCs that's all it is, now I have VTAC, which stands for ventricular tachycardia. It means that we've turned a corner. It means the heart muscle says, I am so mad, I am so upset, I am so sick, I am so ischemic that I have now taken over the pace of the heart. You're going to listen to me now. I'm begging for attention. I've been begging for it for 15 years. But in the last 15 minutes, it's gotten really bad and I can't do any more. And now it's turned into that.
Is that the same thing as SVT?
No. No, it's not. It's close, but it's not. Murphy says things go from bad to worse. If this is left unchecked, it'll go into just a total chaos rhythm with no rhythm. There is no rhythm, and that's called VFib, ventricular fibrillation. Now, instead of having an organized rhythm, now I just got chaos. That means that the cells in the ventricles have all just said, we're about to give up. We can't come together. We can't organize. We can't work together. Everybody's freelancing. Everybody's doing their own thing. Listen very closely. This first rhythm may or may not generate a pulse. Okay? This one may or may not generate a pulse. Let me say this. If it's generating a pulse, is it a good one? No. But it keeps you alive. You may actually have people talking to you with that rhythm, and they're like, I just don't feel it. I feel like I'm going to pass out. And you look at it and go, you're about to know what you're about to do.
Like sirens on those rhythms?
Nope. I can handle this, dude. I don't need you at the ER. I'm a highly trained medical professional. And I should act like I am one. I act like I am one. No. No. Do I need ALS? But Jonah, you're an EMT. You won't see that necessarily. An EMT level doesn't take a heart rhythm and interpret it. Even though he or she knows it's there. Hang with me. This one may or may not generate a pulse. VFib will not generate a pulse. Will not generate a pulse. There's not enough organization for it to do so. Everything's just quivering. It'd be like everybody in this classroom getting so hungry and you just started talking amongst yourselves and we didn't make it out to the common goal, okay? But if you had a leader in here who says, okay guys, this is what we're going to do, this is how we're going to solve this, it'd be different. Things go from bad to worse. VFib will eventually, left unchecked, turn into the flat line that we call asystole. And you remember systole being contraction, and A means without, so asystole means without contraction. But it's in our world, it's flatline. It's flatline. There's no more electrical activity. The cells of the heart are electrically dead. Will it generate a pulse? Absolutely not. Never talk to your patient and go, oh, you're in asystole. He goes, I am? I can tell you he's not in asystole. Your monitor is messed up or you've tripped over a wire or something. How does the EMT, the paramedic, the physician, the nurses, the ER, the bystander who's trained, how do they stop those two at the top? Both of them start with a V, VTAC or VFib. How do we stop that? How do we interrupt that? Well, we're going to defibrillate. Defibrillate. Well, if that is fibrillation, then what is defibrillation? It's to get rid of it. So we're going to apply electricity to the heart. We're going to take, in our case, bystander / EMT, we use automated external defibrillators, AEDs. The EMT brings one with them. The bystander goes and gets it off the wall. And if somebody goes into cardiac arrest here, I'll stay here. And somebody go get the AED for me. Do you know where it's at? As a matter of fact, if anybody ever opens that door and says, Brandon, come quick, one of you please go get the AED. just so it's here. Okay, so you go over into the main health science building over on the carpeted area down by the offices. Middle hallway, it's hanging on the wall. We'll take a trip one day soon to put your hands on it. If you call campus police, they'll bring one in the patrol unit as well. And you should call campus police. You should call 911. I need some help. But one of you are going to go with me and one of you are going to get the AED, okay? If you're riding an ambulance as an EMT, there will be an AED on your ambulance. If you're a paramedic riding on a mobile intensive care unit, there's also an AED there, but it's built into the heart monitor. So I'm going to show you how to use the AEDs on the wall, and I'm also going to show you, we're going to show you how to use the AEDs that you'll find on the ambulance, because they don't buy separate ones. They buy that one heart monitor, and a lot of times the EMT can only activate the AED side of it, and then if the paramedic's there, he or she can punch in a code to activate the entire monitor. Okay? More about that in our lab experience. For right now, we're going to apply electricity to that cardiac muscle, and that electricity is measured in joules. So just let's do a little physics now. A little electrical engineering, if you will. What is a joule? A joule is a watt per second. A watt per second. And you're probably familiar with watts in the term of light bulbs. So if I've got a 100 watt light bulb and I illuminate it for 1 second, that was 100 joules. If I took a 50 watt light bulb and illuminated it for 2 seconds, that's 100 joules. It's a watt per second. Just go ahead and tell you, these AEDs are pre-programmed to deliver 200 joules to the heart. 200 joules to the heart. Now, some people are a lot bigger, therefore it's going to take more energy to get to the heart. Some people are smaller, it's going to take less energy. But what's delivered to the heart is approximately 200 joules. Enough energy to light up a 100 watt light bulb for 2 seconds. It's quite a bit. If it is a pediatric AED or you have AED pads on that pediatric, it's going to deliver 50 joules. You don't have to know this. You don't have to dial this up. It's automated, right? It's going to take care of it itself. Once you go to paramedic, you can dial in a dose. You can dial in a dose. Not on AED, but at the paramedic, you can adjust the joule settings. Yeah. The AED is fixed. All right. You will see, if I was ringing the bell ding ding about test questions, we got a constant buzzer here, okay? You're going to see so many of these questions. Do not get fooled by this. Jonah and Jordan, you're going to be at a little disadvantage here, I'm afraid. Possibly. So y'all need to pay extra attention. AEDs are only applied to people who do not have a pulse. I can't highlight that, underline it, put it in quotes, bold font, all caps. I can't stress that enough. AEDs are only applied to pulseless patients. Patients without a pulse. That means I do not take someone in chest pain and put an AED on them. That does not mean that I allow somebody to talk me into applying the AED on someone with chest pain just in case they crash. Yes, Billy?
So what happens if they're in BTIP? If you can't do anything in that moment?
They're pulseless, so what are you going to do? Use the AED.
Okay, but BTAC's a shockable rhythm, and it can also be a pulsable rhythm. So say you do an EKG, you see BTAC, and at that point you apply AED pads.
Not if they have a pulse.
Why?
Okay. I'm about to tell you. I'm about to tell you. Wasn't that so prophetic? I just knew that I can read the future. One more time. Who gets an AED? Pulseless people that you will attempt resuscitation on. Because we can have pulseless people where I just go, I ain't working on you. You're missing a head. You're decomposing. I'm being funny, but I'm also, when do I not resuscitate? Injury non-compatible with life, decomposition, DNR. Okay? If I'm attempting resuscitation and using the AED, that patient better not have a pulse. To Jonah's point, what did I say about this rhythm, VTAC? It may or may not generate a pulse. If now, please, let's all work together and we'll spend the rest of the day on this if we have to. If the AED is applied to the patient who has a pulse and the rhythm is VTAC, you said it may or may not have a pulse, didn't you? What's the AED going to do? It's going to shock it.
Oh, you're saying on an automated AED. Okay.
Yes. Yes. It does not know if the patient had a pulse or not. Right? That was your determination. You've applied it. It read the rhythm. It will shock this one or this one. Ding ding. What two rhythms does the AED shock? VTAC and VFib. Ding ding. But you just told me, and I told you, that one of these rhythms, VTAC, may generate a pulse. So if you mistakenly or incorrectly applied an AED to someone with a pulse and the rhythm was VTAC, it's going to shock it. And most likely, when it shocks it, it's going to knock it into that. Most likely, when it shocks that, it would knock it into a systole or VFib. I could go into why, but you don't want me to. Let's keep it simple. Who gets an AED? Pulseless people. Do you think I could play PSYOPs with you? Do you think I could write some test questions that say, your patient has pain on level of 10 out of 1 to 10. He's gray, ashen, diaphoretic. He feels like he's about to die. Your EMT partner has brought the AED to the side of the patient. Your next step would be to I'd rather check a pulse, but I brought you the AED, right? I mean, here it is. You're like, let's go ahead and get it on him. Because time is tissue. And if I've got it on him and he does die, all I got to do is hit. No, you put it on, most of them just go ahead and come on. You open the door, open the lid, analyzing heart rhythm. Do not touch the patient. Why does it say do not touch the patient? Riley, can I touch you?
Yes.
I'm going to shake you a little bit. Is that okay too?
Yes.
So if I was to put the AED on her right now and not touch her, it's going to probably find a normal sinus rhythm and it's going to say no shock advised. Okay? But if I was like, come on, Riley, stay with me. I know it's going to be okay. Or if Riley was my loved one and she was unconscious and I was like, come on, honey, stay with me. When you move the patient, it creates electrical activity and it will show up on the monitor. So if she's in a normal sinus rhythm with an AED on, but yet I'm shaking her, or maybe she's just cold and trembling because she's scared, or maybe she is really cold or something. That trembling will do it too. That monitor, that AED, could misinterpret that as that, or worse, that. If you're talking to your patient and the AED says shock advised, somebody's messed up. You should not have gotten that thing out. Ding ding, next test question that'll come up. If you are riding down the road in the back of the ambulance and your patient crashes, goes into cardiac arrest, you find no pulse, what are you supposed to do? Start CPR and get the AED. AED's right here. You put the AED on, it says analyzing heart rhythm. That ambulance better be stopped. Pull over to the side of the road for analyzing of the heart rhythm. The bumping in the road can cause the heart rhythm to be misinterpreted by the AED, okay? When it says stand clear of the patient, that's why they want you to stand clear. So you get when you do a 12 lead in the hospital, Jonah, you have your patients lie really still, because any movement, and it's cold in the hospital and they're quivering, you'll get what we call artifact in the middle of that rhythm, and the AED may misinterpret it. Can I tell you a funny story to kind of drive the point home? It's a teaching experience that I had. So up until a couple of years ago, I taught a ton of ACLS classes, advanced cardiac life support. Taught a ton of CPR classes. That's what we call a canned course. You just teach the curriculum that the American Heart Association gives you, and you're not supposed to deviate from it at all. It's real hard for me because I just sit there and hit play, stop, play, stop. I don't teach. I just run a computer that runs the film. But we have a skills session in it to where we break out. I give a scenario and the students have to work through the scenario. So I had a group of recent nursing grads who had passed their exam. They were licensed as nurses. They were new hires at Texoma Medical Center. I'll go ahead and say it. They hired like 50 out of that group, and we were training them, and I had like 6 in here. And I had the mannequin. And one of the scenarios I have to run them through is management of chest pain. It's pretty easy. Position of comfort, oxygen if needed, nitro, aspirin, acquire 12 lead, consult with a doctor. All right? Pretty straightforward. Get a history. Well, that was the scenario, and they applied the AED. They activated the AED. I've got it all here. It's all at your disposal, right? You got a whole bunch of stuff at your disposal. Doesn't mean you're going to use all of it. They applied the AED. Speaking on behalf of the patient, right? I'm mocking myself as the patient, and I'm like, what are y'all doing? And they're like, we're applying the AED, sir, just in case you have a heart attack. And he's like, am I really having a heart attack? And they're like, we don't know. We'll have to wait till the doctor looks at you. But we're just in case. We're going to take real good care of you. Now, don't worry. And I'm like, okay, if you say so. And because they turned it on, it said, analyzing heart rhythm. Do not touch the patient. And I'm like, what's that mean? And they're like, it's just taking your heart rhythm, sir. It's okay. We're going to take real good care of you. And I'm like, I hope so. And it says, shock advised. Charging. So you hear the capacitors build up. So the capacitor takes the charge from the battery and builds a whole bunch of it up and then delivers it all at once. Okay? That's the job of the capacitor. And you can hear those, we call it capacitor whine. They're winding up. When they take that charge, it's an electrical noise. Stay clear of patient. Press the orange shock button now. Bam! It's over. One of them says, check a pulse. They're like, He doesn't have a pulse. And this is the mannequin, right? I'm just the voice. There's a mannequin here. They're like, we lost the pulse. Another one says, start compressions. And they started compressions, and then somebody said, oh, we should breathe for him too. Okay, it's 30-2, right? Well, somebody better get the doctor in here, and blah, 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 blah. Well, they do a few compressions. Guess what the AED does? Analyzing heart rhythm. Stay clear of patient. Well, it shocks from VFib back into where we started. At least that's how I made it, because I'm trying to drive a point home here, and it goes back, and then the guy's waking up going, what happened? And they're like, sir, you had a heart attack. Don't worry, we're going to take real good care of you. And I'm going, I hope so, it hurt. Once you start an AED, there is an internal timer. And for every 2 minutes, it's going to analyze heart rhythm. Here it goes, analyzing heart rhythm. And I said, please don't let that do that again. That hurt so bad. And I don't remember after that. And they're like, sir, we're going to take real good care of you. They hit the ass again with some more electricity. And they did CPR till they were busting out in sweat. I never came back to life. And I said, y'all got to come with me for a minute. They're like, what did we do wrong? Did we do something wrong? And I'm like, yeah, you killed the poor guy. All he needed was a little nitro. He didn't need so you gave something without an indication to give it, right? It was an act of omission because you didn't use the nitro and the oxygen and the aspirin. It was an act of commission because you applied something with no indication to apply it. You incorrectly applied a treatment. If that had been real life, could they have gotten sued for negligence? Abso-freaking-lutely. If anybody had told on them. Jonah, Jordan, I don't think this is common practice anymore, but come to find out, there was a bad practice in the facility to where people were applying the pads to chest pain patients. Once you apply the pads, you're just a micro inch away from hitting the AED button to activate it. And depending on the monitor, it may automatically activate because there's automated and there's semi-automated and all that kind of garbage. Who gets the AED? Pulseless patients. Do you have to be still to analyze it?
Yes.
That means nobody's touching him, he's not on a waterbed, and he's not in the back of a moving ambulance. It has to be a stopped ambulance. Yes, sir.
Can you apply the pads but disconnect the AED from the pads?
Why?
To make it quicker whenever shit does go.
Bad practice. It's bad practice for a couple of
Is
reasons.
it just because you don't want to freak them out?
Huh?
Or is it just because you don't want to freak them
No.
That's what we do at teams.
I know. It's bad practice. It's bad practice. It's bad practice. I just can't help but say it's bad practice. Time to defibrillation is important. The longer a patient sits in a state that I've got drawn up there, the less effective defibrillation is. As a matter of fact, once it goes past 4 minutes, the odds of survival drop to almost zero. Let's be real. So, good luck EMTs and paramedics. It's going to take you 4 minutes to get to the scene if the dude was in cardiac arrest before you got there. Odds of you saving that are very slim. Because time is tissue. Murphy's working. Things tend to go bad to worse. What's more important, Jonah, than defibrillation in the early minutes, and please understand, I said defibrillation was important. Compressions. If I'm in a hospital facility or if I'm in the back of my ambulance and I have a chest pain patient, suspect MI, he's throwing a lot of PVCs. Guys, if this PVC gets real close, see this wave? You think I'm just drawing stuff out of random, don't you? Huh? Everybody thought, man, he's just drawing shit out of random. You see that bump at the back of every complex? You see that bump? That's called a T wave. If that PVC gets close to that T wave, and as a matter of fact, if it falls on the first half of it, that's called the relative refractory period. That means the cells are kind of charged, but not fully charged. And if they get this weird impulse from somewhere else, if that falls on that, it goes to that. It's called R on T phenomenon. If that falls on that, it results in that. Okay? So granted, Jonah, I'm in the back of the ambulance as a paramedic, and I'm looking at the ECG tracing going across, and I'm seeing that. I'm like, oh, things are about to get goofy. Or I start seeing 2 or 3 of those PVCs pop up in a row, and then I'm like, man, if I get more than 4, I've got VTAC. Damn, I gotta be doing something. What I should be doing is not putting pads on. What I should be doing is drawing up medications to numb that, chill that. Cells, get a grip. Let me give you something here. I give them an antidysrhythmic drug like a small dose of amiodarone and a small dose of lidocaine or something like that to kind of squash that irritability. Does that make sense? I mean, if I'm going to do surgery on your arm and I cut you with no pain medication, it's going to hurt. Those cells will be irritated, won't they? If I numb you up with lidocaine, you don't feel the cut. Basically the same thing is going on in the heart. I give you the lidocaine, it kind of numbs the electrical signal of the heart. The patient crashes. I have all of this within reach, just like you have it within reach of the ER. Patient crashes. What should I start immediately? Chest compressions. While I'm doing those high quality chest compressions, I hope I've got somebody with me, and I think in the hospital you do. How long does it take to open the pads and put them on? Really not that long. Really not that long. Putting those pads on prior to that is bad practice. And I know you're saying, well, if they're not connected to the machine can't interpret it. If I got a machine over here screaming, and some of them do, I'm not saying yours does, but some of them do, connect pads. Connect pads. Connect pads. Shit, we better connect the pads. Right? Some of them will tell you when the pads aren't connected. Apply pads. Apply pads. You're like, it's kind of like the autopilot in a airliner. Too low. Too low. Like, you're going to fix it. Some people have the habit, and they are taught this way, and I will teach you this way. What is the first step of AED use? Turn it on. Ding, ding. What's the first step in using an AED? Turn it on. Second step, follow the prompts. I'm going to grill that into your head. Follow the prompts. That's what's taught in the BLS classes. That's what's taught in the ACLS classes. Then you modify that practice in reality by putting pads on prematurely. Jonah, these pads are often called combi pads, meaning they have another purpose other than defibrillation. They're also pacing pads. If I need to pace the heart, I'll use the same pads to do it. When you start getting heart monitors, sophisticated $100,000 heart monitors that you'll have in your ambulance that take blood pressure, temperature, they measure capnography, they measure SpO2, they can do 12-lead EKG, they can transmit the EKG, they can be an external pacemaker, they can be a defibrillator, they can be a cardioverter. That's a lot for a paramedic, right? But when you give an EMT or a nurse the ability to jack with one of those without oversight, oh, it gets bad in a hurry. It gets bad in a hurry, especially to someone who may be least not very experienced. And I'm going to be as blunt as I can. They're hiring nurses with no experience and putting them to high critical areas of the hospital, ERs and ICUs. You used to have to earn your stripe to get into the ER or the ICU. No, we're shorthanded, get in here. You got a card and a pulse, let's go. Same way on the paramedic side of life. We're letting these paramedics run day one, on critical calls without any clinical experience. That's a recipe for disaster. And that's why I say it's just bad practice. It's bad physical practice too, fiscal practice, money, because I don't know. I know in the ambulance they're at least $100 a set, and you're putting them on and then don't use them. You can't reuse them. Would you want to talk further? I mean, I'm not to beat up on you or your practice or anything. It's just
No, I agree with
you. Are you understanding where you can see things could go really wrong in a hurry? And there's another part of this too that I guess I should add to it. I just told you, you don't have to know any of those lines on the board at the EMT level, and neither does a nurse. Your job is not to interpret that. The only reason I'm telling you that is because that's what the AED is looking for. I'm telling you that to drive the point home. And plus you're going to hear that jargon when you get on the ambulance with a paramedic. I'm going to leave nurses alone for a minute because they're not in here to defend themselves. I'm going to beat up on paramedics a minute. If you're not real cool in your ECG interpretation, but you should be. Remember I told you got to make 100 on a math test to get out? You also got to make 100 on your ECG exam to get out. So we're going to throw up about 25 heart rhythms. You got to identify them within a few seconds. But some people will turn the monitor on, it will trace out something, and they will activate the AED to see if it's VFib or VTAC. I've seen them do it, and I'm like, what are you doing? Well, I really don't know what the rhythm is. I thought it might tell me. Yeah, it might, and it may go shock advised. Charging. I make a big deal out of it for obvious reasons. I told you I'd give you the big long-term buzzer on test questions. The National Registry loves to try and bait you down the road of putting an AED on to someone who doesn't need it. Why are they doing that? Why are they doing that? Why are they doing that?
Kill someone.
Why are they doing that?
Because it's happened.
Because it's happened a lot. And they're making an increased effort to stop doing this. It's one of those deals, because I can, I will. Just because you can doesn't mean you should. Don't do it. Don't do it. There are a lot of don't do's in this business. There are some absolute don't do's in this business. The AED is not the cure-all. If I send you for the AED because somebody's collapsed in that hallway and in cardiac arrest, well, let's hope like hell somebody's doing high-quality chest compressions. There's also this theory out there too, and it's supported with science, that if a person's been in arrest for a period of time, just like maybe I got the call and I arrived on scene and I asked Miss Jones how long Mr. Jones has been in the kitchen floor on his back not breathing. And she says, at least 5 or 6, 10 minutes before I called you guys, I was trying to wake him up and he wouldn't respond. So I decided to call 911. You're like, there's 10. Took me 10 to get here. By the time it went through dispatch and a drive, that's 20. Due to anaerobic metabolism in the heart cells, how much lactic acid is built up in there? How much oxygen is in there? None. How well does a sick sick cell respond to a defibrillation attempt? You wouldn't think very well, would you? And there's some science and research that says in those cases, it's probably better to do the 2 minutes of CPR, a couple of cycles at least, to get the blood moving, blow off some CO2, get some oxygen in before I attempt a defibrillation attempt. In other words, we're delaying the defibrillation in order to give it the best opportunity to work. Does that make sense to you? And you think, well, no, man, I'm taught that VFib gets defib. You're correct. VFib does get defib. You think, so that means I got to apply it as soon as possible. I agree. But if you were to follow the algorithm, it always says send someone after the AED. And that's what gets me about a BLS course, a CPR course, if you will. It doesn't really apply to how we work. And you got to tweak it a little bit for the pre-hospital person. I'm not a fan of it. I don't like it. I can teach you everything. I'm going to teach you everything plus more than the card course gives you, because it's our business. Now, if I'm teaching a lay person or a physical therapist or a dental assistant or a floor nurse or somebody like that, yeah, sure, be familiar with it. But it's our business. May I say this, and I hope it burns into your brain, and then I'll give you a break. If you think, as an EMT, that American Heart Association BLS card is what you've got to do, is the standard you have to meet, you're selling yourself short and your patient short. Now, Stephanie Cooper is our AHA coordinator here. She's going to be involved in us granting you your card. Okay, and she's very stickler about doing it correctly, and she should be. I'm not faulting that at all. We need to be. But guys, it is your bare minimum standard. At this level, you should be taking it up a few more notches, okay? So we're going to show you how to do cardiac resuscitation alongside of a paramedic. And we're going to be using the auto pulse. We're going to be helping them set up the defibrillator and the IVs and the medications and stuff like that as well, all right? It's your business plus. Yes, Billy? You're going to get a new one anyway, but if you didn't get a card, you guys would know more CPR than a card holder. You cool with that? It's gotten to the point where the American Heart Association and the National Registry have kind of had a divorce. They just, because we realize this is our business. Why do I need a card? I don't get a card for bandaging and splinting. I don't get a card for managing anaphylaxis. I don't get a card for med administration. It's just one of our skills. But in other allied healthcare, it's probably not a primary skill, is it? You don't expect the dental assistant to be highly familiar in cardiac resuscitation. They're going to call who? Us. So we should be. Should they know how to do CPR until we get there? Yes. That's all the card's doing, is verifying that you can do CPR until experts arrive. And we are the front door of the experts, so we're going to do better than that. Same way at the paramedic. ACLS card, Advanced Cardiac Life Support. If that's your standard, even the American Heart says this. This is baseline. This is baseline. Take this baseline science and apply it how you see fit in your environment. It's a lot, isn't it? There is a lot of information rolling out at you, and it's going to keep rolling. I'm not going to say that's it. It's it in December, and then it's going to hit you again in paramedic school. But we're in charge with bringing back the near dead. How could that be easy? We can make it as easy as possible. Any other questions so far? Now we're going to take a little bit deeper dive into why the heart cells get into these rhythms, and then we're going to get into some treatment of how to keep it from getting into that. And it's all just a summation at this point. fine tuning and summation. And I hope you have questions as we go through it. Anything before we take a break? Okay.